time of the questions, and the third and the second and the fourth one. Then after the fourth speaker has deliberated, we'll take the questions. The question will be shorter, not allowing everybody maybe not to ask the questions, but we will ask the questions after the fourth speaker. Now we're going to call upon Professor Stephen John. Okay, with his bio. Professor Stephen John is the co-director of the Health Systems Program at the George Institute for Global Health, conjoint professor of health economics at the University of NSW, and professor of health systems at the Imperial College in London. He is an honorary professor at the University of Sydney, a director of the Sachs Institute, and an associate at both the Menzies Center for Health Policy and Poche Center for the Indigenous Health. He is a current equivalent of the SAMRC Principal Research Fellow, and has previously held posts at the London School of Hygiene and Tropical Medicine and the Center for Health Economics Research and Evaluation in Sydney. Prof. John has over 20 years of experience in health economics, and he has published over 200 scientific articles and authored 2 textbooks in the health economics. He has worked closely with various governments of different levels, both in Australia, Commonwealth and state, and overseas, with international agencies such as WSU and industry. His areas of expertise are economic evaluation, health financing, health sector priority setting, indigenous and global health issues, and the economics of chronic diseases. His areas of expertise also are economic evaluation, health financing, indigenous and global health issues. He is also a member of the Lancet Task Force on Non-Communicable Diseases and Economics. He has worked with governments, both in Australia and overseas, and with the international agencies such as the WHO and industry. He has a strong interest in training and organizational capacity building in the health technology assessment, and has been involved in the projects in China and India to investigate the translation of HTA evidence into government decision making. And at the moment, Professor Stephen John will be talking to us about universal health coverage, financial protection, and cancer care. Over to Prof. To the podium. Thank you.
Thanks for the introduction, and firstly, very grateful for the invitation to come here and to meet you all and to be part of this launch. It's a very exciting initiative and really grateful to have the opportunity to speak to you. So the presentation today, I'm going to take a slight sort of deviation from the theme. I will talk about some of the work that we're planning around community health workers, particularly in South Africa, and it's a project that we're hoping to get funded around the use of community health workers in cancer care. I'll talk about that at the second half of this presentation, but in the first half, I want to sort of focus a bit more on aspects of universal health coverage that we've been doing quite a bit of research on in the last few years through my team. As you heard in the introduction, a lot of my work revolves around health economics and health financing. And we've done a number of studies that examined the impact of non-communicable diseases on patients in terms of their out-of-pocket costs and catastrophic expenditure. In the last few years, we've also been looking to do some more work in this area South Africa and Africa in general. So I'd be keen to hear your thoughts about some of the work that we've done in the past in this space. So I feel this is an opportunity to maybe present some of the work more broadly that we do and open up discussion about potential ways in which we can collaborate further in future. So thus my topic's a fairly broad one. It's around universal health coverage and cancer care. So just a bit of some introductory comments about this work that we've done in the last few years. So you've probably come across this definition before, what universal health coverage is. This comes from the WHO. It means that all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. And obviously, a big part of that definition is the economic side, the fact that people shouldn't be facing major financial burdens and barriers when they're accessing care. And I understand in South Africa, we're in the process of instituting national health insurance as a way of trying to address this problem. This particular statistics is a little old, but it hasn't been updated, but it just gives you a sense of the scale of the problem. So about 100 million people a year are pushed into poverty as a result of illness. And about 150 million per year experience financial catastrophe. So that means a level of expenditure that is defined as catastrophic for the household. And I'll talk a little bit more about that definition a bit later on, but that's a sense of the burden. In South Africa, out-of-pocket expenditure as a percentage of health expenditure is 5%. So that's down from 15% since 2000. So you're doing well in terms of out-of-pocket burden. And hopefully you're going to do better with universal health coverage, national health insurance coming in. That's the plan, but what we found in the past that health insurance isn't the only fix for financial protection, and sometimes health insurance can actually increase costs, and we can talk about that later in the discussion. But hopefully in the next few years you'll experience a further improvement in that statistic. I was just trying to look for more information in South Africa. Illness-induced poverty from out-of-pocket expenditure is less than 1% of the population per year. It comes from a study from Koch and Getso in 2020. So again, that's promising, and that's a lot better than many other countries. The incidence of catastrophic expenditure from cancer care, and as you can imagine, the expenditure on cancer care can potentially really skyrocket, particularly once people get into advanced stages of treatment. 47% in middle-income countries, and astonishingly 74% in low-income countries. So that means 75% of people who get cancer in low-income countries experience financial catastrophe. So that's a huge problem in terms of universal health coverage. So against that background, we did a study a few years ago, and it was in Asia. And as I said, it's something that we want to sort of try to replicate in Africa. Financial catastrophe, treatment discontinuation and death associated with surgically operable cancer in Southeast Asia. It's called the ACTION study. And the aim of the study was to determine the economic burden on households in Southeast Asia associated with the first-time diagnosis of cancer. So this was a large study of about 9,000 patients, but this particular paper that I'm reporting here was a sub-study of those patients who were indicated for surgery. So this cohort of 4,584 consecutive adult patients with a first-time diagnosis of cancer, and who, as I said, were indicated for surgery. The 47 hospitals, and we did interviews at baseline at 3 months. And the outcomes that we're looking at 3 months were, so there were 4 potential outcomes you could achieve at the end of 3 months. Firstly, you could be hospitalised with financial catastrophe. So that's obviously a bad outcome. So you get treatment, you get hospitalised, and you experience out-of-pocket costs which are greater than 30% of your annual household income. You can be hospitalised but experience no financial catastrophe, so that's ideal. That's the best outcome because you had surgery, you've been hospitalised for that surgery, but you haven't experienced financial catastrophe. You can experience no hospitalisation. In other words, you've discontinued treatment. Surgery is indicated on your plan, but you've not even proceeded with treatment, and to a large extent that would have been attributable to the financial barriers, or you could have died. And they were the 4 outcomes we were looking at. And I won't go into too much in the methods, I'll just give you the results. So 31% of participants incurred financial catastrophe. So a third of patients experienced costs that exceeded 30% of their income. 8% had died, 23% discontinued treatment, and 38% continued treatment and avoided financial catastrophe. So from what you can see, only 38% achieved what we would consider a good outcome. Some of the details around those results. So women had a higher risk of financial catastrophe than men. Health insurance, not surprisingly, was significantly associated with a lower risk of treatment discontinuation. High income had a lower risk of death, lower risk of financial catastrophe, treatment discontinuation, and financial catastrophe. Not surprising. Higher income, the better off you're going to be in terms of outcome. Lower education, not being in paid work, experience of economic hardship at baseline were generally associated with higher risk of death and treatment discontinuation. So again, not too surprising. The worse you were in terms of education, the worse the outcomes were likely to be. So in conclusion from that study, health insurance coverage protects from financial catastrophe and encourages continuation with treatment. So not surprising there. Cancer and the need for surgery result in a many-fold elevation in the risk of financial catastrophe versus general populations in Southeast Asia. Women are particularly vulnerable to financial catastrophe associated with cancer, and so efforts are needed to offset the costs of treating female cancers in particular. And socio-economic disadvantage are most likely to incur adverse outcomes, and that would reinforce a spiral where economic disadvantage, we know, predisposes you to a greater risk of illness, which in turn predisposes you to a greater risk of economic disadvantage, which then perpetuates a potential cycle. So the findings from this study, it was an observational study, it was done in 8 countries, and we published it. One of the, very positive outcomes was that it attracted a lot of attention. And in particular, in the Philippines, where the study was done. And at the time, the Philippine Senate was considering the implementation of what was called the National Integrated Cancer Act, which was going to establish a national program of cancer control, and was going to provide financial coverage, so reduction in out-of-pocket costs for people seeking cancer. And a debate over this act, Senator Angara cited the findings of the study as support for this this new act. And eventually the act was put in place, and we've recently, I haven't reported here, but we've recently continued our collaborations with colleagues in the Philippines to try to evaluate some of the programs that have emerged as a result of the act. And as you can see here, this research potentially develops into a longer-term relationship where we can track the possible impact of a study on policy and then see how that unfolds over a number of years. So, look, I was thinking a bit about sort of the implications of this study and the work that we might be doing through the centre with colleagues such as Sikumbuzo. And, what impact do out-of-pocket costs have on treatment decisions? And I wanted to sort of see what the literature says in an African context. And to be honest, there isn't much literature. And so one of the, as you saw in this study, the impact of out-of-pocket costs isn't just in relation to economic hardship experienced by families. It also impacts on people's treatment decisions. And sometimes you may find that once you have high out-of-pocket costs with treatment, that conversely, you may actually see low levels of economic hardship, largely because people are deterred from going to treatment, so they're not incurring those costs in the first place. So what we need to look at is not just the incidence of financial catastrophe and poverty associated with treatment, but we also need to look at the impact on treatment decisions, and that can manifest in things such as the failure to initiate treatment, treatment abandonment, non-adherence. And two studies I found which looked at this in the African context. One study in sub-Saharan Africa looked at childhood cancer abandonment rates, found that they were 7%, much higher in Ethiopia. 34% of childhood cancers resulted in abandonment of treatment. And this was a question that we looked at more broadly when we did a global systematic review of treatment abandonment for childhood cancer. So this is a problem where families, when they have a child who's been diagnosed with cancer and they face the prospect of treatment and the potential out-of-pocket costs of that treatment, and we wanted to look at what were the rates of treatment abandonment for childhood cancers. And in particular, what we wanted to see was whether there were any differences by sex. So whether girls experience a higher abandonment rate than boys. Essentially, that was our hypothesis. And you can see why that might occur because of gender norms in certain places where maybe a higher value might be attached to the life of a male son, a child, as opposed to a female child. And it's a question that we wanted to explore in this particular review. We did a systematic review, a meta-analysis, and happily we found, I won't bore you with all that text, I'll just give you the results from. We found pretty much no difference between males and females in terms of treatment abandonment rates. The only thing that we didn't account for when we planned the study was in some settings there was a difference, and in particular in India. There were 4 studies that were done in India which did show a pro-boy, pro-male bias in terms of abandonment rates. But generally speaking, across the rest of the studies, there was no difference in abandonment. So that's abandonment. We've also done some advocacy work through the Lancet Commission that we on NCDs and economics, and part of that was a review that looked at internationally the burden of NCDs on households in terms of catastrophic expenditure. And we found from the studies that were available that households who are not insured, that means national insurance or private insurance, had no level of insurance, associated with 2 to 7-fold higher odds of experience catastrophic costs associated with out-of-pocket expenditure. Protection was often offered by health insurance, but it was often incomplete. So you often found people, even with health insurance, experience catastrophic expenditure. Health insurance alone isn't a panacea because often health insurance coverage has gaps, has deductibles, has co-payments, has gaps in the benefit package, and people can slip through these gaps and still experience high costs. To enable the coverage of chronic costs associated with NCDs. So NCDs basically are chronic conditions. And by that I mean that they're sort of long-term, they're predictable, and providing health insurance coverage for chronic conditions is a different proposition to covering infectious diseases where there's an acute phase and then people recover. Chronic conditions mean lifetime costs, and for an insurer, that's a very difficult proposition. And particularly for private insurance, they'll often find ways in which to avoid covering people with chronic conditions because it's a surefire loss leader. If you're providing financial protection with somebody who's on renal dialysis, for instance, as an insurer, all you're doing is paying costs. There's no risk associated with it. You're just going to make loss. So in a commercial market, insurance for non-communicable diseases is often non-commercially viable. And so what we argue in the Lancet Task Force on NCDs and Economics is that if we're looking at providing financial protection for people, particularly when we're talking about the burden of NCDs, we're going to have to look at schemes that involve compulsory enrolment or financed through taxation. In other words, publicly funded national schemes rather than relying on private insurance. So that's just a bit of background to some of the broader work that we've been doing around universal health coverage and out-of-pocket costs. And as I said, we want really be keen to see if we can do some similar work through the centre in South Africa and Africa. Here's a piece of work that we have firm plans to do, and which we put in a proposal last year to the NIHR, which is a UK funding agency, to look at community and frontline health workers in the prevention and management of women's cancer in South Africa. It's called Confront Cancer. So it's a partnership between Walter Sisulu University, Imperial College, University of New South Wales in Australia, and community and frontline health workers in rural Eastern Cape and Mpumalanga provinces in South Africa. So the idea is to co-develop locally relevant programs to improve knowledge, increase screening for breast and cervical cancer, and support women in accessing follow-up care. And so the rationale and background for this study. So these are statistics, again, that are probably not surprising to you. 2018, cervical cancer resulted in 5,600 deaths in South Africa and 4,700 deaths for breast cancer. 2017, South African government introduced a national strategy aimed at early detection for screening, referral and treatment. It also recently introduced the national insurance system to facilitate access to care. So all these things are highlighting positive sort of policy intent in terms of improving access to these treatment for these cancers. However, there are a number of barriers to success here. So they include poor health literacy, cancer stigma, delays in screening, referral, diagnosis and treatment, poor coordination of services, shortage of skilled health professionals, financial and logistical barriers. So in terms of some of the work that's been done previously in this area, so there were 2 studies in 2023 that found that hospital and primary care nurses lack knowledge on cervical cancer and an understanding of its importance. At the same time, the WHO recommends screening for cervical cancer as well as for breast cancer in low resource settings. So these have been shown to be cost effective and can be performed by community health workers. So despite the existence of national strategies for community screening of cancers, the uptake of these programs has been poor, particularly in rural regions. So the aim of this study was to, as I said, co-develop a community education and frontline worker training program to improve cervical and breast cancer screening. And associated with that, referrals in communities in South Africa, so not just screening, but improving referral channels to care. And to evaluate the effectiveness, cost effectiveness and implementation of this program. So the specific objectives of this study would be to co-develop and adapt the intervention, to understand the barriers and facilitators of implementation, to then implement it through a cluster randomised controlled trial and evaluate its effectiveness and then evaluate its cost effectiveness. So so the methods that we would use, so it would be a cluster randomised of a trial of a educational intervention for frontline health workers in the 2 provinces. The participants would be frontline health workers and women in the 30 to 65 year age group. And there'd be a following baseline survey of villages in South Africa, which will be then randomised to the intervention and control arm. So, as I said, inclusion criteria 30 to 65, exclusion criteria prior history of cancer of the cervix or breast, or those who were screened in the past 5 years. And the control group would be the usual care, so no further interaction. So the primary outcome that we would be interested in, once we've randomised and run the intervention and compared between the 2 groups, would be the proportion of women eligible for screening who were screened for cervical cancer or breast cancer since baseline. So we're hoping to see improvement in screening rate, which is an obvious primary outcome. Secondary outcome would be proportion of women who were screened just for cervical cancer. The other secondary would just be for breast cancer. Then we'd also be looking at knowledge of cancer, and knowledge of cancer in the community, so knowledge amongst women in the community, knowledge of cancer amongst frontline health workers, and it would also conduct an economic and process evaluation. So in terms of outcomes and significance, so as I said, this study hasn't been funded yet, so it's not certain it's been done, but if we're not successful with this grant scheme, we're going to try somewhere else. So eventually I feel that this study will be done. It's just a matter of finding the right funding program. But in terms of the outcomes and significance of the study, what we hope to see is we'll assess whether the intervention leads to an increase in screening, improvement in community and health worker knowledge, and improved access to follow-up care. Secondly, we'll develop community-based programs to address the existing barriers to screening that result in preventable deaths. And then thirdly, more broadly, we'll build community and workforce capacity. Thank you. I welcome any comments and questions.
Thank you, Prof, for the wonderful presentation. At the moment, please take a seat here in the orange couch. Yes, and wait for the time for the questions when everybody is done with the presentation. At the moment now, we are calling on our next presenter. I thought somebody will raise a hand and ask me, where is the second program director? He disappeared in the group here in the center, and now we are going to see him wearing the second cap. The first one was being a program director, now is a presenter. The presenter now is Dr. Luvuyo Bayeni. Dr. Bayeni has done MPC HB at Medunsa and MBA at Nelson Mandela University. He's a product of Eastern Cape Department of Health, having served in the following roles in the department. He was the clinical manager. You can't hear me? So this one? Sure. As I was saying, he has been serving in different roles in the department. The second role was a provincial program manager for circumcision. The third one, he was acting as a CEO in Tower Mental Health Hospital. The fourth role, he was acting as a CEO in Livingston Hospital, and also acted as a district manager at Joe Gabi, and also acted as a technical advisor for MEC Health. Now, he has been borrowed by National Department of Health to serve as a chief director responsible for human resource for health. Let us welcome Dr. Balen to the podium to do his presentation.
Thank you very much, co-program director. I think because I'm home, she's giving hope to home that I'm just borrowed. So anything is possible. I may come back if I'm borrowed. Or you can go and demand me back because I was borrowed. Thank you very much. I come bearing gifts. Someone has donated and I'm proud to be the winner of the Ford. There was a draw, there is a Ford that has been won, so I'm the winner of the Ford. You'll get your key later on. Thank you very much. I've just been asked to just highlight and brief on how we have been doing in terms of the Human Resources for Health Strategy 2030. And in terms of the approach, it's just to flag where we come from and what are the parameters of the strategy and how we have been doing as a department. And of course, we have been consistent in trying to remind wherever we go, especially when it comes to reminding people of the patient journey and highlighting what does health encompass. We do note that indeed we would expect ordinarily patients to be picked up, EMS, and then sent to primary healthcare, referral system, and all that. But the reality, colleagues, is that the system is not always controlled by us, and patients would sometimes do what they think is appropriate for them. So if you see there that there is footsteps and there, it does not mean I have been asked to be a brand ambassador of Hang 10. I am not promoting Hang 10. It just tells you that a patient can walk in here, walk in there, walk in there, walk in there, without necessarily following what you prescribe to them in terms of the pathway. So that's what it means for us to say, in terms of the healthcare system as well as human resources for health, we just have to have all that patient journey in mind to say, how do we capacitate the system, how do we prepare, and how do we plan in terms of the workforce management. But importantly, what is key for us now in this round is the part that talks about retention to the relative investment that has been made. Because the health workforce is not only so much about bringing new, but it's about what do you do with what you have. And if we've been investing, how do we then get value add out of it and realize our investments thereof. But of course, we have also been mindful that at the end of the day, we are dealing with trying to sustain a healthcare system, which of course has got its own limitations, but also should be anchored in something that is fundamental as to what is it that we want to achieve. And what's important is the base here, especially these two blocks of people that are executing they are executing capabilities as well as the operations. And what we're saying in terms of the HRH, we should always be mindful that as much as we need people at the top to lead us and to tell us, but our outcomes depend on these two people in terms of what impact we want to have. So in whatever we're doing, we should be able to try and balance and see if we cannot try and make a difference and focus on the issues that deal with the focus core business as well as the organizational structure issues. I came across and I felt this one is also applicable to my space and the work we do at HRH. Productivity is never an incident. It is always the result of a commitment to excellence, intelligent planning, and focused effort. So that's what keeps us going in the HRH space, as we learned from Paul Mayer, that at the end of the day, if we all agree that we want people to be productive, we must put in some intelligent planning, but also we must appreciate that there would be efforts that each and every one of us must put in. HRH must be led, and there is an intentional approach and an intentional focus on issues that deal with leadership within the strategy. Because amongst other things, it's a realization that you need the strategic leadership capabilities for health workforce for us to move forward. So there is some reference that is there on the strategy that deals with the issues of strategic leadership. But what we are saying as well in terms of leadership versus hospital governance, there are elements and principles that we are advocating for and trying to highlight to say, at the end of the day, we need to know what governance is, because now we are saying there is leadership vacuums, there is governance deficiencies, but we're not there to guide to say, how do we then strengthen this space of governance, especially within the hospital space. So we are also expecting that there'll be some achievement of strategic goals even from the hospital space, sound board CEO relationships, because we do have hospital boards, we do have CEOs as managers, but we're not sure of what type of relationship is there between the two structures. And of course, we want the institution to be led such that there is a unity of direction, unity of command, unity of accountability and responsibility as well. But of course, we must never shy away and not forget that there is also a notion of public ownership, self-improvement, equality management, as well as understanding the cost of governance. But of course, there is also an issue of the organization we are in. How do we lead it? And what are the issues that we want to ensure that in the health workspace, health space, what is it that we want to achieve? So we are reminding that there is issues of development of comprehensive clinical governance framework, but importantly from the HRH perspective is that we need to educate workforce on key aspects of clinical governance framework, highlighting their responsibilities for improving safety and quality. And not expect it that it's an issue of a clinical manager, it's an issue of a nursing manager, or an issue of a doctor or a nurse only. But our health workforce within the facility should understand that all of us have got a role to play, especially towards improving safety and quality. But of course, we need to review policies and procedures, as well as review the results of clinical audit. The same goes with clinical leadership, that we need to understand and also perform delegated responsibilities. But importantly, is the issue that talks to issues of conducting clinical audits to ensure that clinicians operate within the clinical framework. What I am being paid to come and talk about is this one. The issue of HRH strategy, this is what I refer to as my Bible since I was borrowed from Eastern Cape. It's a green book, and I try to make sure that I understand all these chapters. I might add in some few hymn books, but this is my Bible. The department has endorsed in 2020 an HRH strategy which is having a time span of 10 years up until 2030. So it's appropriate for us now, because we are in 2025. We refer to it as a midterm, and we just need to reflect and see whether we're coming or going. But the purpose of the strategy is to facilitate implementation of sustainable comprehensive health workforce interventions. But also it's underpinned by the issue of consistent supply and management of a competent health workforce for optimal contribution towards meeting the population needs. Especially in this time or this era of limited resources, one of the things that we are highlighting from an HRH perspective now, and when I preach, I always wish that I'll have people that are converted and will have more disciplines, disciples, as Jesus Christ was doing in his journey. So now, when we meet people that raise challenges of money when it comes to employment, we are reminding that in terms of the healthcare system or the health workforce, whether there is money or not, we must be reminded that a health workforce in its nature, it's a key driver to inclusive economic growth. If you don't have a healthy society, whether you bring investors or not, that country would not succeed in terms of its economic drive. So that's what we are trying to say to people who've got money, that even if you must limit it, but understand when it comes to the health workforce, we are contributing to the economic growth. So an investment in contributing to decent work and job creation, particularly for women, is what we are also trying to remind all those that are talking about investment in terms of human resources. But of course, at the heart of an efficient and well-functioning health system, when empowered with optimal skills mix, distribution, competencies, and standards. So what we are also bringing to the fore is that, yes, we are all excited that we are heading towards universal health coverage. In South Africa, the component or the model that is being chosen now is that of an NHI. But the reality is that without any human resource interventions, it is there clearly that there can be no delivery of universal healthcare coverage without skilled and enabled and supported healthcare workforce. But also we are also trying now to move in the line of economists as well. So when you talk about us in terms of human resources, we are reminding and adding to the whole discussion of finance and investment that we are also a capital. If you go around and ask anyone that you want to start a business, they'll ask you, do you have capital? So whatever space you are in, when you talk something that has got to do with investment, business, and productivity, they'll ask you about capital. And our issue is that we are saying, we are this capital, and people must start taking us serious. Because whether there is money or not, there's a lot of capital we are bringing. We are bringing knowledge, we are bringing creativity, we are bringing abilities, skills, education. So we are the capital that all the sectors need in terms of surviving, striving, and improving. So that is our language now. So next time when you talk to people, tell them that human resources for health, we are the capital, human capital that the organization needs. And please convince them, as I continue to convince them to give us money. We've got 5 goals in terms of this Bible of ours. The first goal talks about effective workforce planning to ensure HRH is aligned with the current and future needs. The second goal talks to institutionalizing data-driven and research-informed health workforce policy, planning, management, and investment. The third one is about producing a competent and caring multidisciplinary health workforce through equity-orientated, socially accountable education and training system. And I think earlier on, that's what the discussion about the models of mid-levels are also trying to remind us and talk to. Ensure optimal governance and building capable, accountable strategic leadership and management in the health system. And lastly, build an enabled, productive, motivated, and empowered health workforce. Those are the 5 goals that we are trying to achieve in this 10-year patina. We've been in the strategy now for the last 5 years. We are heading towards the closing it in the next 5 years. So now, just to reflect and give you a sense of what we've tried to achieve or how far we are. In terms of the first goal that talks about effective workforce as well as planning and alignment, we are very much considerate of education and labor market needs, supply and demand mismatch, as well as the filling of funded positions. But we can confirm, colleagues, that we have tried to move. If you look at the 3 main objectives in that goal that talk about the HRH strategic functioning, we feel that we have achieved that. And we are still promoting and enhancing and encouraging provinces to develop their own provincial strategies. The strategy also was pushing or motivating that we should establish what we refer to as a health workforce consultative and advisory forum to meet 6 monthly, but also amongst its tasks is to ensure that there is an annual HRH in Daba. So we can report to you that we have managed to launch that last year, as supported by the partners, and it's supposed to be in its first year of term this year. The third issue on this goal is about achieve consensus on health workforce planning approach or model, including financing of health sciences, education, and training. We are actively participating with the department having co-chairing platform in what we refer to as the Joint Health Education Science Education Committee, JSEC, which is a platform that is between Department of Health as well as the Department of Higher Education and Training. But we have gone further to rope in Department of Treasury, National Treasury, to participate there. So we have moved there. Terms of reference have been approved in that space. So we are seeing some light. The second one that talks to the data issues, loosely translated, we talk about health, human resource information system. We even have a directorate that deals with that in the department. So initially we're supposed to explore research conducted on HRH and access progress. We had a limited internal capacity on our part, so we haven't moved, but through platforms of such as these and the networkings, now we know where to go to, and we'll be able to start implementing that part. Of course, we are also proposing upgrading of PESAL system from the generic of health specific to linkage. Where we want in this space and where we are heading, we have achieved it, but we are improving on it. By the time we end this term, when I meet anyone in the street and they say, I am Dr. Luvuyo Payeni, I will say, okay, what is your ID number? And then I'm done. From that, I would click on the button and I would know if you are registered with any council, where are you practicing now? Are you in the state or are you in private? And that's what we want to achieve, so that we have a sense of who are the health workers in the country, whether they are in private, we're in the Bahamas, but we should know as to who are the health workers in the country. And then, of course, that information will be harmonized with the statutory bodies so that we know exactly, because all of us, we know we must register. Even though you are still enjoying your holidays somewhere in the Bahamas, but registration with the council always comes first. So we'll make sure that we know who exactly you are. But we want to create a data warehouse, and we are busy consolidating that. There is a program called Accelerator Program that we are working on. Like we have said on the first one, the issue of research unit, we still have to action that one. Education and training, determine resource requirements and mechanisms for decentralized training platforms in the health space. We have reviewed the guidelines of the regional training centers that will be presented at the National Health Council Tech as well as the NHC. We can confirm that last week we had a 2-day session with all the provincial regional training center managers. So there is work that is moving in that space. Engage professional councils to develop a unitary approach to core competency curricula for all health workforce. We still have to action this one, but we are having access to the Joint Committee of Deans for Health Sciences faculty. The issue of strengthening relations with academic institutions, that's why you could gladly extend your invitation to us, and we are here, and I'm not here alone, I'm here with my boss. So we are making sure that relations with academic institutions are strengthened at all times. And the issue of higher education, we did mention that there is joint committee which deals with that. On governance, governance principles, I think the first 3 slides I was mentioning was indicating our approach in terms of governance issues. But the other issue that is important for us is the issue of making sure that we we safeguard the public interest. And I think from our perspective as a department, one of the things that is coming up that we are very much concerned about is the caliber as expressed by the ethical and behavioral issues that we are seeing with the caliber of our graduates. So we are very much concerned in terms of public interest as to, are we producing the right caliber? Are they having the public interest at heart? And it is our responsibility as a department to make sure that we safeguard that place. People management, that is now goal number 5, review of available remunerative incentives. So my colleagues, I did not come with the issue of reviewing committed overtime. It was signed off in 2020 when I was still working in Eastern Cape. It did not come with me. There, you see it now. It is not me, it is in the strategy. So we are reviewing our policies, colleagues, all 5 of them, not only committed overtime, community services is being reviewed, rural allowance, OSD. So it is a strategic issue. And of course, it is necessary because with time you need to know, are some of these incentives and policies still relevant? Is the applicability thereof still the same as when we started before? So that is where we are. But of course, we're still interested in attraction and retention. As a department, colleagues, whether we've got money or not, we still strive and want to be the employer of choice. But of course, we are saying we are not the only employer. And that's what people must understand. When you are a graduate, public health is not the only employer, but we want to be the employer of choice. So there is that balance that people must understand. And of course, we need to review the issue of performance management tools. But importantly is the issue of a welcoming and a conducive working environment. That is where we are busy hammering and drumming into our provincial counterparts that we need to really take serious the issue of employee health and wellness and make sure that we are responding to the strategy of creating a welcoming and a conducive environment. And of course, we must ensure that we minimize the risks that are there with the health workers at risk. I think that is where our labor friends know that we also take them serious, that we don't want them to be at risk in our workspace. So we have done some work there where we have also tried to assist the employee wellness team to launch a national employee health and wellness forum last year in August. This is just to explain what do we mean by the Health Workforce and Consultative Forum. It is in the strategy and it is well prescribed as to what we expect out of it. And just to ensure that we are moving towards a stakeholder engagement opportunity where we feel as a department we cannot do everything alone, especially when it comes to issues that deal with the health workforce. Research has been presented here earlier on, practices and exercises have been presented, and this is what our Health Workforce Consultative and Advisory Forum is going to assist to say, where are we now? What is the relevant information and where do we think we can do better going forward? The membership is a joint membership between us as a Department of Health, where there's 5 officials from the department nationally and 4 from provinces. We also have sector departments, SAMS and DHED, as well as partners. We've got academia, strategic experts, professional councils, as well as the private health. in conclusion, colleagues, ours is just to remind and to report in actual fact that we are very mindful that there is an urgent need to improve leadership, especially when it comes to clinical governance. Because whether you look at it from a litigation point of view or from efficiency point of view, we feel that if we can strengthen and do much better in clinical governance, we can try and achieve certain things. But also the implementation of the strategy has been impeded by financial constraints, as evidenced by the National Treasury decline in terms of funding elements and strategy thereof. But also health reforms provide an opportunity for review of the strategy to align with the preventative healthcare as well and attain universal healthcare coverage. So there is nothing wrong with us reviewing even the strategy itself to see if we are still in line. And the other issue is that there is an urgent need to address internal culture. As an organization, colleagues, I don't think we are telling lies when we say the organization needs some cultural review. Whether you look at it from the perception of work ethics, coming on duty on time or late, staff attitudes that patients complain about, our own efficiencies as managers, wastages, and all those things. So there is a need for us to just look and address our internal culture as an organization. But importantly, especially from an HRH perspective, earlier on there was a presentation that was talking about mentoring. We are saying maybe that's what we need even more. That let's try and find a culture of coaching and mentorship within the organization, and of course having expertise from outside. We go around advocating that let's prioritize and align, especially with partners and sectors that can ensure that the strategy is used as a planning tool even in their departments. And like I've mentioned, we are proposing and continuing to advise provinces to have their own internal provincial strategies, because there are things that are unique to different provinces. We might be reviewing rural allowance, which is very much relevant if we're talking Gauteng, for instance, where, by the way, Val will tell you that they feel they are more rural than Johannesburg, so they also want the rural allowance. But here you've got your Lusikisiki, you've got your Mkandulis and all that. So provinces must be able to look at their own provincial strategies to be able to meet their needs, especially when it comes to issues of retention and attraction, because that must talk to what is it that we are saying as Eastern Cape. And of course, we want to make sure that goal number 5, which talks to our wellness, is also prioritized, even as provinces. We have also requested provinces to look at what we refer to as focus and strengthening of the nursing and EMS college capabilities with a detailed project plan, because we know both colleges are coming from a backlog of having to meet needs and requirements by DHET. But if you look at it now, we seem to have just left them alone. We are not there to say how then do you maintain those standards that you have submitted to DHET. The issue of the clinical governance, I think I've overemphasized it, and that there must be some leadership from the clinical governance side. And lastly, we are saying this time around, we want at least to go along and also introduce issues that deal with monitoring and evaluation in terms of healthcare workforce issues. In all human affairs, there are efforts and there are results. And the strength of the effort is in the measure of the results. So if we don't have results, this effort of us being here might have been regarded as being useless by other people. So it's always important that we must make sure that there are results to just strengthen what we're doing. Colleagues, there's gold in human resources for health, but the only problem is if you are pulling apart, the other one wants to go that side, the other one is going that side. So we are here to say, let's work together. Let's all go and dig the gold. Let's see how we can make use of it, whether it's talent, whether it's mentorship, whether it's support, and whether it's appointments, but let's work together as a team. Thank you very much.
Thank you so much, Doc. You can take a seat on the orange couch. You'll be waiting there until we are done with you asking questions from you. And oh, the boss is here. Yeah. And Dr. Payeni now is finished with his presentation. And now we are going to invite on the podium Dr. P.C. Mahlat. Then now, when you were talking of him, I'm going to introduce him, although I was cautioned about this. Dr. Percy Mahlati founded the African Institute of Health and also runs the Selizwe Leadership Academy. He serves as a Deputy Director General for Hospitals and Human Resource at the Department of Health of South Africa, a role he has served in an earlier stint as well. Before then, he was a COO of the South African Medical Association, whose formation he spearheaded. Dr. Percy contributed to health policy development in various aspects, but chiefly in the health workforce field. He played a major role in the development of the World Health Organization's Code of Practice on international recruitment of health personnel and participated in the core expert group on health worker retention in remote and rural areas. Previously, he chaired the Ethics Institute. He chaired the Ethics Institute of South Africa, and he was a member of the Council of the University of Limpopo. Dr. Percy received his MBCHB from the University of Natal Medical School, now the Nelson Mandela School of Medicine. His Masters of Philosophy from the University of Stellenbosch, and his PhD from the University of Fort Hare. He has a certificate in advanced management from the Manchester Business School. He is a board member of Fort Hare Trading Solutions at the University of Fort Hare Company. He is a fellow of the 5th class of the Africa Leadership Initiative, South Africa, and a member of the Aspen Global Leadership Network. He has recently self-published a book entitled Strategic Management of Professional Health Workforce, a South African Policy Perspective. And now I hand over to Dr. Percy to deliver his speech. Thank you.
Thank you, Mandobanga Mameli. No, thank you very much. I will try and go through. I was asked to talk about building HRH capacity. Oh, okay. In the light of limited resources. And you will all remember that there was something called Circular 49 in 2023 issued by DBSA in conjunction with Treasury, which was basically limiting the employment in public service. So that would be in the context of that, followed by the austerity measures that, have been strengthened over time. But I thought, let me start by saying that, of course, we're experiencing challenges in funding education and training and linked to employment. That is, you educate, you train, you graduate, but then the employment. But I want to emphasize what Dr. Bayeni said earlier on, that the fact that you've been educated using state money does not entitle you to be employed by the state. We seem to have major problem, especially with our young doctors, who actually say because they're educated by the state, therefore they've got an inalienable right to be employed by the state. I think we need to actually deal with that because no other profession has that in its mind. Number two, there are lingering challenges in HRH. Some of you hopefully are advanced enough to remember that Professor William Pick produced a report in 2001, which was looking on human resources for health. And there have been several studies, including the country contributing massively to quite a number of, studies and work by the WHO. And of course, there is one thing that we have managed to keep on as a country, training, quality, under and postgraduates. That is the reason that they would remain in demand across the world, because nobody recruits poor quality. They always go for best quality. 1994 we had a big problem because when the world started recruiting nurses, they actually went for our most experienced nurses, theater nurses, ICU nurses, even those that were working in the wards, were experienced managers. And we found ourselves in a big challenge. That is what later led on to the OSD, because of those experiences, because we're trying to find out how do we respond, policy-wise. One of the major leaps that has been taken has been to peg nursing and EMS at higher education level. But I thought, let me just share with you what the different accountability roles are. As the National Department of Health and basically the health sector as a whole, we've got to define the skill demands and training parameters for our health sciences. That is why in the National Health Act, no new qualification can be introduced without the Minister of Health acceding to it. Not even the Health Professions Council, whoever can do that. That responsibility lies squarely and 100% with the National Minister of Health, because it's a mechanism to try and equate the demands with education, requirements. Higher education and training must make sure that there is effective planning for the supply of healthcare professionals. That is why education institutions, they actually have to submit to the Department of Higher Education and Training their 10-year student planning, so that the department would then be able to lobby for funds to be able to fund, those programs. They must go through the Council on Higher Education, follow all those accreditation processes. So you get the national department this side saying this is the caliber we need. Then higher education would say, okay, that is what you need. CHE, you engage with universities, colleges, what quality would be required, therefore what quality programs are there. Then you get to a national treasury that says, what is it going to cost? So that they can be able to then say what kind of subsidies they're actually going to provide to the universities to be able to do that. So the higher education institutions are responsible for curricular development and quality. Provincial health departments then come in providing the employment platform over and above the training platform and research platform. So if you actually look at those four, of course there are others like your medical research, which actually conducts the burden of studies, projects for us, so that then we can be able to know where the challenges are. Because if it is estimated that in the next 10, 15 years, these are the problems that we are going to have in terms of existing and new diseases, medical research should then sound the warning. So there is that complex, relationship between all. It's not just limited here. There are many others, but I thought I would just take this. I'm spending a bit of time here because it's important for us to understand what the different responsibilities are. So you cannot get a university just setting up a program, enroll students without ensuring that both Department of Health and DHED are in agreement. I'm not going to name. There are universities that have done that before and have faced litigation afterwards because they invited people to enroll and say, no, you'll get work in the public health sector, only to find later on that is actually, In Zulu, they saying amangal hlaza, you know. So, what funding streams do we have? We've got a variety of funding streams that Dr. Bayen here is putting his head together with our, finance people to say, how do we harmonize this so that we stop having multiple sources of funding that would end up, clashing against each other. We've got a clinical training grant. There's subsidies to education institutions from higher education, bursaries to students and trainees, the health professions training grant. There is private funding. It may not be that big, but it's actually there. There is also the health and welfare sector funding that we have not exploited to the full, that we should. Of course, there is need to streamline and ensure equity, because there is a challenge that you find some programs are more funded than others. And those that are less funded, you might find that the ones that are more needed at a primary level. An example is the rehabilitation professions, physio, occupational therapy, audiology, speech therapy. Those are not funded, adequately. But those are actually that you need, because of the various challenges that we have. Of course, I won't go through a lot of that. I think the second one is very important to highlight: limited spaces for under and postgraduate education and training. We actually are doing well undergraduate, but postgraduate we've got problems. And if we don't produce specialists now, in 10 years' time, we'll actually kick ourselves and say the consequences of a decision that we took are hurting us. Remember, specialists across all categories, especially nursing, if we don't deal with those, we're going to have a problem. Limited posts for employment in the public health service. Of course, that's a function of a functioning or non-functioning economy. Overloading of public health facilities. Then I would just want to emphasize the last one. Major problems with economic development. A general youth unemployment that we're facing. Professor Cheta is not here. There is a character that we share between me and him. Seyithetha injalo into. If you look at your program, it's got some insertion there that iphume ecaleni kule nto kuthethwa ngayo apha. It says 10 years ago, it was unheard of for a doctor to be unemployed. Where did we go wrong? So you can interpret that in various forms. It's asking a genuine question, but then that genuine question, why should it be asked of doctors only? Number two, it could be showing a siege mentality. And uyayibona nalo sisu lapha uthe. She's really under siege. That relates to the last bullet. Our country has got a serious problem of youth unemployment. We've been seeing it far. It's come to our doorstep in the health services. Yes, we must cry foul, but we've got to find ways of dealing with it. And it can't be government alone that deals with it. Professional associations like SAMA are very important. SAMA to whoever it is, to deal with that problem. So I'm actually saying that is, to me, it looks like a siege mentality. That, look, we've been so privileged, the privilege is going away, and the whole world is coming apart. It's not coming apart. And it will not come apart. As long as we agree that we are going to solve that problem together, I will share with you what we need to do. Mitigation, Dr. Bain talked about Joint Health Sciences Education Committee. That's a committee between ourselves and DHED. I'm one of the co-chairs with another DDG from DHED. We've pulled in National Treasury to that. One of the things that we've got to do is to define a long-term vision. It's one thing to talk about invest more money in. If you are putting more money into a system that does not have a vision, what is going to happen? The participants there are going to be fighting each other. So the question of leadership is very, very important. So we must define a long-term vision. So we've set up a team that's going to look at that. The other team has to look at the data that we'll use. Where do we collect it? How do we collect it? Where does it get stored? What analysis do we get out of it? And therefore, what information for planning do we actually get out of that? That will inform funding. That will also assist a lot with our research and policy. So those are the 4 subcommittees that we've set up. Now, there is Department of Health, Department of Higher Education, National Treasury, 3 representatives of the deanery in the country. We've actually pulled in the education institutions. We've also pulled in the regulatory bodies, your HPCSA, Nursing Council, and so on, because we want all those that have got to deal with higher education to be under one roof so that we address the same problem. But there are certain operational efficiencies that we need to do. One, we've got to look at new forms of employment. Shift work started in Limpopo and doctors ran up and down. But unfortunately, these are some of the things that we actually have to look at. We've got to look at reviewing other HRH in retention incentives. I'm going to pick up commuted overtime because that one is the most simpler, and maybe the RWAPs. Let me start with RWAPs. In Dr. Baini's presentation, there was a slide on clinical leadership. That is the seniors that provide leadership. But if you've got a senior who's going to come to 8 o'clock and pitch up at 5 o'clock, what do you think the juniors are learning? We are setting a bad example for them. You are away most of the day, then you come back, you want to be paid for the whole day, and you feel entitled to that salary. I must be paid, you know. I was available on the phone. You are not employed to be available on the phone. You've got to be there physically, you know. RWAPS is that problem. And I must say that RWAPS has started with us as administrators, CEOs. You know that the guy is not working, but you actually, you know, turn a blind eye. Instead of saying, look, for this week you actually worked for 10 hours instead of 40, so you'll be paid for 10 hours. And see whether the behavior is going to continue. Many of them say that I'll leave to the private sector. Many years ago, it's my second life in the department now. Many years ago, I had a colleague at Bongani Hospital in the Free State who was faced with that problem. Said, no, these ones are trying to go. I said, call them tomorrow, give them pen and paper to write their resignation and go. There were 4, only 1 signed, the other 3 didn't. Because they know what it is in the private sector. I'm from there, I know it. It's not easy. So people hold you to ransom because you fear that they know, look, just test it. It's okay, go. They will go and come back and want sessions. Why do they want sessions from you? It's not about giving service, it's something else, you know. Commuted overtime. Eastern Cape has a budget of close to R1 billion on commuted overtime only. That's excluding salary. And for it to employ the doctors that are unemployed, it needs 348 million So the question is, why not take that of that billion? You just take 500 million. You employ more people, you leave 500 million or 400 for commuted overtime. What's difficult with that? Then doctors jump up and down. No, 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 no. We want that. Because if you've got 4 doctors and you can employ 6 more, the demand for overtime on the 4 is going to reduce. Simple. Simple reasoning. I don't have to be like Prof. Asamani here, who actually thinks a lot about figures. I just use simple reasoning. We're afraid to take those decisions. Then we complain that we're understaffed. We don't have money. We do have the money, it's inside. And I'm happy about provincial treasury is put a foot down on it, that I'm aware. Limpopo decided to go on shift work, and with the money that they saved, they were able to employ up to about 400 recently post-community service doctors into the system. So why would we refuse that it does that? Because then we're saying our colleagues who are young must actually be unemployed, while we actually benefit from, what in many instances we're stealing from the public. I know that the word is going to come out and say that UPS said doctors are stealing. I'm not saying that. But we do have some rotten apples in our profession. So if we don't deal with those rotten apples in our profession and think that treasury is going to pump money, forget it, it's not going to happen. Take it from me, it's not going to happen. Unless we improve on those operational efficiencies and say, what is it that we can trim so that we can be able to get others? You all do it. The cost of living has gone up. You've trimmed your monthly, shopping. You don't buy all those niceties that you used to buy 5 years ago. You buy the basics so that you can feed your families. Why can't we do it? So that we can get these young people in and make sure that the seniors are there to train them. Medical litigation can be connected to that clinical leadership slide because young people are training themselves. They are making mistakes that end up costing the state. And we don't take it back and say, look, Professor Mahlati, where were you when juniors were making this mistake? These are some of the issues that we've got to, and I'm prepared to be on stage to actually, discuss those issues. Going towards the end, we have to make sure that there's frequent engagement at strategic level. Policy developers, the deanery, and the funders. That is why that joint health sciences education committee is set up like that. We need to encourage innovation. We have to move at fast speed on interprofessional education and training. If we don't do that, we cannot sit with training that has been like this for 20 years, 20 years, 30 years. And the innovation must be led by education institutions. Of course, we need to jointly assess the long-term impact of global developments in science and technology. There are new technologies that are actually advancing quality of care. And I always say to people that, I'll use the old example. When laparoscopic surgery, he'd got to do it. So what are the questions that were assessed with, at that committee level? How do we create an innovative, collaborative, and adaptive learning environment? How must the vision be integrated with the notion of development? We always talk about South Africa being a developing country, a development, a trajectory and all that. From an education and training point of view, how do we, integrate that? How should the vision position the country internationally? How do we make sure that our health workforce remains internationally, globally competitive. I think we've had examples here, where in terms of research, twinning and all that. Of course, if we reduce our standards, they will dump us. How do we make sure we actually keep it high at that level? Of course, very important, how should we finance the vision? South Africa took a view before 1994 that we are going to be a country that advocates for human rights across the world. That's a very clear vision. It's been costly, but it saved so many nations across the world. It's been a beacon of hope for humanity across the world. So take it in that, view. How do what we do actually assist, not just to propel the country forward, but also to make sure that the advantage that we have actually remains. So just one comment that there was an issue about the community health workers who are grappling with a challenge. We've got about 50,000 community health workers in the country. And the big challenge is, do we employ them in public service or not? And in the light of the challenges that have come with that man with that hairstyle, across the Atlantic, you know who he is, We've been actually put in a tailspin, but fortunately, we buy our own medicines. But from an employment point of view, 15,000 people suddenly becoming unemployed is a huge headache. So there is a lot of work that we actually still have to do around that. The other one is the Nelson Mandela Fidel Castro, a medical training program in Cuba, which seems to be going down and then going up. And there are huge challenges from a financing point of view. We do hope that WSU will be able to come in as a strategic partner to localize that program so that then we can, over time, stop sending our students there, but they actually be trained here. Thank you very much.
I did know that the audience will do it without being told you can clap for dog. Now, without wasting the time, because time is a little bit against us, we've got the last speaker before we can have our questions to them. Now, we'll be calling on to join us in the podium, Professor James Avoka Asamani. Professor Asamani is a health economist and health system expert who works with World Health Organization as the team lead for the health workforce for the African region. James' core experience is in health systems, focusing on the health workforce, health economics, health planning and policy, and decision analytic modeling in health. He has published widely in those areas. Before assuming his current position, Professor Asamani worked as a World Health Organization technical advisor on human resource health systems, leading technical support for 20 countries across East and Southern Africa. He also worked as a health economics advisor in the WHO country office in Ghana, and previously was the head of health workforce planning and budgeting unit of the Ghana Health Service. As a health decision scientist, Professor Asamani has led several transformational initiatives and conducting cutting-edge health system analysis that have impacted health policies and planning across health system in Africa. And his recent works on using health labor market evidence to shape planning has stimulated thousands of jobs and hundreds of million-dollar investments from governments and partners across several countries in Africa. Prof is a Commonwealth scholar with a PhD in health sciences, specializing in health modeling and workforce planning from the Northwest University in South Africa. He also has an MPhil degree in nursing, specializing in healthcare management and human resource for health from the University of Ghana, and an MSc with distinctions in health economics and health policy, specialized in decision analytic modeling from the University of Birmingham in UK. As a health force planning and health labor market methodologist, he has developed tools and methods currently used by more than 15 countries across Africa, Southeast Asia, the Americas, and Europe for health workforce analysis, policies, and investments. Professor Asamani is an extraordinary associate professor at the Center for Health Professions Education, Faculty of Health Sciences, Northwest University, South Africa, where he contributes to research and supervises doctoral students. He is also an editor in several globally reputable scientific journals. That is Professor Asamani. Let's give him a round of hands, then you can over to him. Thank you, Prof.
Thank you very much, Madam Moderator, for the very kind words. And good afternoon to everybody. It is usually a bad time to stand in between people and their lunch, especially when they are tired. So I am very much aware of that, and I would skip many of the slides that I prepared because the previous speakers already did justice to most of them. And it's usually very hard to speak after a luminary like Dr. Percy just finished talking. So I might only end up confirming a few of the things he told you without numbers. I may just put a number around a few of them, but there's nothing really new here. So I have been invited to discuss with you around health labor market analysis in selected African countries, and particularly looking at projections to 2030 and beyond. Because we have done labor market analysis in so many countries, I decided to look at what is the overall picture across Africa, and where appropriate, I mentioned a few countries as examples. Okay, sorry. Okay, so this outline is what is in the slide. It will be made available. Hopefully, Professor Mabunda would share with you if you may need it to use for something else. Now, the WHO Africa region, we typically work with 47 countries in the continent of Africa. In these countries, in 2022, the total deaths are deaths that resulted from things that could be averted if they had access to good quality health services. So we say they are amenable to health interventions. Of that, 48% of them died because they used the health services, but it was of poor quality, not good enough to save them. But they could have been saved if the services was of good quality. 52% died because they simply did not use the health services, they didn't have access. Now, if you take a look at this one, this is number, but it represents human beings. It could be anyone. You could have all the money. You could have all the connections. But if you unfortunately fall in at a place where the service is so poor, you might receive the service, but will not survive it. If at a place where the service does not exist, you don't even stand that chance. I will come back to this. So think about them as a quantity problem for where the 52% who don't have access, that's a quantity problem. And then for 48% who have access but still die, that's a quality problem. And you can argue that this would be connected to many aspects of the health system that you already saw from Professor Robina, right? Robina's presentation. But much of it also depends on the caliber of workforce that we produce. I will not repeat these ones because Professor Robina and others spoke about this, showing us that if you look at the workforce per capita, that is workforce per 10,000 people, in 2006, compared to 2022, Africa still remains like a place for bloodshed. 2006, the darker areas where we have fewer workers, 2022, nothing much has changed, despite all the big efforts that has been made. But to understand all of these issues, we are going to look at this from an economic angle. So a health labor market angle. If you typically go to a market, you buy and sell. You make choices as what to buy, who to buy from, what price to take and what price not to take. And the ones selling also make decisions about how much to sell that they can make their profit or at least break even, and how much that they can go below that. That is what we are basically going to do. And this particular diagram you see here is the theoretical diagram we usually try to follow, starting from what makes somebody wanting to become a health worker in the first place. In terms of education, we try to quantify. And from there, they qualify to join the pool of health workers. Some bound to find jobs, others maybe not. Some will be forced out of the labor market through debt, through retirement, change of jobs, among others, and some might migrate abroad. And of those employed, where are they working? In the health sector itself, in the other sectors, among others. And are they adequate to provide health services that the population really needs? Are they doing the right things in terms of quality? Are they distributed? But 3 quick points before we proceed, though, is that I will touch on these 3 points. One is the supply of health workers, which is how many people are available, trained, and ready to work. That will be influenced by your education pipeline, how many are coming in, and how many will come in from abroad. And that is the inflow. And it has an outflow, which would look at retirement, death and disability, out-migration, and career change. All of this would influence how many workers you have going forward. And you will see later that South Africa actually needs to start paying attention to this one.